Hi, I'm Roxana Mehran. I'm an interventional cardiologist, professor of medicine, population health science and policy at the Icahn School of Medicine at Mount Sinai in New York. The SMART trial, the first pre-specified endpoint of the SMART trial was to evaluate the outcomes in women. The first time we are seeing very, very important data on women with a small annulus, which is actually quite a common finding in women who present with severe aortic stenosis. They often have a small aortic annulus. The choice of valve matters. And the SMART trial actually looked at a intra-annular balloon-expandable valve versus a supra-annular self-expanding valve, Evolut versus Sapien. Over a 12-month period, there was a 1-to-1 randomization. We had 637 women. 90% of the population were women. And that particular analysis was incredibly important and historic. The patient population were all women, average age of 80, severe aortic stenosis, a small annulus, randomized to Sapien versus Evolut, and followed through 12 months. Well, we had two co-primary endpoints in the main SMART trial. And for this sub-analysis, similarly, we looked at the composite clinical outcomes of death, disabling stroke, and hospitalization for heart failure. And that was powered for non-inferiority, and we met that endpoint, no difference between the two. The second co-primary endpoint, powered for the female women enrolled in SMART, was the hemodynamic outcomes, the bioprosthetic valve dysfunction through 12 months. And the key finding there absolutely was that there was a major statistically significant difference, a 33% difference in incidence of bioprosthetic valve dysfunction, much lower in the Evolut group compared to the balloon-expandable Sapien valve. This is significant because hemodynamic changes and bioprosthetic valve dysfunction, specifically with prosthesis patient mismatch as well as high gradients, they're all associated with worse clinical outcomes. And it's for this reason we're following the patients out to 5 years. We expect to see a difference in clinical outcomes down the line. Well, obviously, incredibly important in the choice of valve, and that what we need to take away from this is that valves are different. There are different hemodynamic consequences with the different valves, especially in a small annulus. A small annulus is extremely predominant in women, and we now have a choice in choosing a valve that is hemodynamically superior over a 12-month period compared to the other valve, and that would be the self-expanding Evolut valve. It's supraannular. It gives a larger, because of the way it's structured, it gives a larger orifice, effective orifice area, lower mean gradient over 12 months. Whether this ends up having an important clinical implication, we have to know. So far, no, through 12 months, but that's early for valves. So we need to see that down the line. So I think it really tells you that we need to think very, very deeply about our patients, their phenotype, how they present, what they have, what their anatomy is, and choose the right device for the right patient. My huge take-home message is that we need to do a better job in diagnosing aortic stenosis, especially in women. We need to make sure that they get the proper evaluation and that we make important choices in terms of valve type, follow them through, and really look forward to improving their outcomes. And most importantly, that it is absolutely possible to have women enrolled in clinical trials. They're often underdiagnosed, underappreciated, underrepresented in clinical trials. This trial showed that if you enrich your trial with a criteria that is more prominent in women, you will get women enrolled. And that's exactly what we did. 90% of the SMART patients were women. And now we have answers for women. And that, to me, is extremely significant in care of women and improving their health outcomes. Well, the longer-term follow-up is exactly what we need to do. And then we need to continue to think smartly about how we design clinical trials to be sure that we're more inclusive, that we're not just studying a certain patient population that fit the criteria of our trials, but rather representative of the patient population, more inclusiveness.